Hi, and welcome to Myositis Support and Understanding. My name is Jerry Williams. I am the founder and president. We are honored that Dr. Weihl has joined us today for new insights on sporadic inclusion body myositis pathogenesis. As you know, it's Myositis Awareness Month, and our theme is Myositis in Focus. As part of our commitment to patient education, today we are placing inclusion body myositis in focus. Dr. Chris Weihl is a physician scientist at Washington University School of Medicine in St. Louis. He has both a clinical and research interest in hereditary and sporadic forms of inclusion body myopathy and inclusion body myositis. Dr. Weihl cares for patients with inclusion body myositis and has a commitment to training the next generation of physician scientists. We have heard many wonderful stories in our support groups about how caring Dr. Weihl is with his patients. So, Dr. Weihl, we thank you for joining us today.
Thank you so much for joining me. Like Jerry said, I'm a physician scientist, so I think of myself as having many different roles. I think of myself as having a role as a clinician, so I do see patients. I see patients a day a week in a multidisciplinary clinic, specifically seeing patients with muscular dystrophies and myositis, and in particular age-associated muscle weakness. And then I do the research lab as well. And the research lab we have about 10 people that work with me in all different stages of their training, whether it be students, PhD students, or whether it be undergraduate students, or whether it be postdoctoral fellows, or even emerging physician scientists. So as Jerry said, that's another avenue of what I do. So I think of my job as having a commitment to patient care, a commitment to understanding research, a commitment to training the next generation of physician scientists. And then I really truly believe, and more so in the later aspect of my career, that patient advocacy, patient education, and increasing awareness is really something that I am called to do as a physician scientist. And so this is a great opportunity to do this, and so I appreciate it. I'm going to talk about the pathogenesis of inclusion body myositis, and you're going to hear my take on it, my opinions on it. It doesn't mean it's right, but it's the way I think about it. And so I just want to kind of share that with you. I'm happy if there are questions. My goal in any talk to anybody is that everyone understands me. And so if you don't understand something, please say, hey, back up. Can you repeat that? I'm not sure I understand what you're saying. So I really, I don't want to just get through a talk. I want to make sure everyone understands what I'm talking about. And that, to me, makes it more fulfilling for me. So don't feel bad if you say I didn't get that. Because I want to make sure people understand. So I'm going to share my screen. So everyone should be able to see, I guess, my screen now. Is that correct, Jerry? Okay. And so I put this up here. This is the title of what I was going to talk about. I also have, I want everyone to know that there are a lot of people that are helping with funding for IBM research. And so it's not just small places that are doing it. The NIH funds my research. The Muscular Dystrophy Association funds my research. The Myositis Association helps out. And then there are smaller kind of homegrown groups as well. And I list two of them, Cure IBM, who that's who I heard about this group from, and then Catalyze for a Cure. The Hope Center is something that WashU has. So I want to put that up there just to let people know, because I won't want this group to think that there's only a few people that are interested in this. There are lots of people interested in it. And one question I often get asked is, how do you get more research into IBM? How do we get more people? How do we get more money? And really, the money's there. It's how do we get people to start asking those questions. And the NIH, it doesn't care what it funds. It just wants to fund stuff that's good. And so if we can train younger individuals, if we can demonstrate that patients are vested and interested in research by them supporting smaller pilot projects that we can then move forward, the money is there from the NIH and from the government. It's not that we should be lobbying our congressmen to say, hey, fund more IBM research. That potentially that could work, but the mechanism is there, which is if somebody's doing good science and is supported in an academic institution and can demonstrate that they are successful, they can get research done. And so I just make that statement just because often people want to know, well, how do I get more research done, and why aren't people studying this? And I think some of it is increasing awareness, and some of it is just there's small ways of enticing researchers into doing into switching their research to study things like IBM. So many of you already know about sporadic inclusion body myositis. It's a rare muscle disease, about 5 in a million. That's what the prevalence is stated. That's probably under the amount, and we'll talk a little bit about why that is, but that's the data that's out there. If you got on Wikipedia, it would say 5 in a million. The onset is typically greater than the age of 50 in 80% of patients, so most patients are over the age of 50. 60% are men. I put this data up here because it can give us some insight into understanding the disease. Is there something different about men than women? I would say in my experience, it's more like 50-50, but the data suggests that 60% are men. It causes insidious, and I put insidious down because I think that's really the key word that captures this disease. It's very slowly progressive to the point that often, and it may not seem that way later in the disease, but earlier in the disease, the slowness of the progression makes people discount the weakness that they have. Not only the patient, but makes the physician discount the weakness because it's so slowly progressive that it's often thought of, well, it happens just whenever you get older, or you're just getting, your back injuries acting up again. And so the insidiousness really is part of the disease, that it's slow. It's asymmetric, and that's a key feature from a clinical standpoint, is that it doesn't always affect both legs or both arms at the same time. It's asymmetric. It has proximal and distal weakness. That's actually a very unique feature for a muscle disease. Most muscle diseases cause proximal weakness, difficulty raising your arms up, difficulty getting up out of a chair. Those are features of IBM, but IBM also has features of weakness in your fingers, weakness with grip, which is distal, and weakness in your ankles. And so those are distinctive features that we think of. And so I bring that up because I think we want to be more mindful of how do we educate not just other patients, but how do we educate clinicians in recognizing this kind of unique pattern. Let's see. And so I learned a lot from understanding this disease by looking at the pathologic tissue. So by looking at the muscle biopsy, I think that we can understand the pathophysiology of this disease. And so I'm going to take it from that standpoint, where we're going to look at a muscle biopsy together, and we're going to point out the features of the muscle biopsy, and then we're going to understand how that could lead to understanding how this disease happens. And so this is a muscle biopsy from a patient with inclusion body myositis. Many of you have probably had a muscle biopsy. Many of you have probably had more than one muscle biopsy. And this muscle biopsy happens to have, just in this image right here, has all the characteristic features that we think of in inclusion body myositis. I'm seeing if I can you guys see a cursor? You guys can see a cursor. And so the features that we think of, so I want to orient everybody. So this is a muscle fiber. And so this picture right here basically is a section through a patient's quadriceps muscle, so their muscle above their thigh. And it's a section that's gone then crosswise through it. And so the way I'm going to say it crudely, but this is what your steak would look like. This is the steak that's been cut into a single section of steak. And this white stuff here is the marbling of the steak meat. And in between this is where the muscle fibers are. And so this is a single muscle fiber. This is a single muscle fiber. This is a single muscle fiber. Even this little guy here is a single muscle fiber. Even this little teeny thing here is a single muscle fiber. And that's the feature that you see in a myopathy, which is that you see really large or normal sized fibers, and you see little teeny fibers. And you see a variation in fiber size. That's the first feature that you think of in a muscle disease. IBM also has features where there's these little blue dots everywhere. This is inflammatory cells. So we all know that inclusion body myositis is an inflammatory muscle disease. And so this is all inflammatory cells that are around and invading, in some cases, the normal muscle fibers. The other feature that we think of are the degenerative features. And so you can see that this is a nice pink-looking muscle fiber, whereas this is not as pretty looking. And even this one right here has little holes that you can see in it, and holes that you can see in it here. And so those are what we call the rimmed vacuoles. And so those are the features that we think of. We think of a muscle fiber that has a myopathy. So that's the first thing. It has to have a muscle disease, meaning that it has to have big fibers and little fibers, and an increase in the marbling of the meat. So an increase in the white connective tissue. So that's number one. Number two is it has to have inflammation. And so you can see the inflammation here. And number three is that it has to have this feature of rimmed vacuoles, or holes within the fibers. And those are the three classic features that make up the biopsy in inclusion body myositis. And so this is a really spectacular biopsy because every feature you can see in this one section. Often patients will get a muscle biopsy and they will not have some of the features shown. And that might be why somebody is confused in the diagnosis. That might be why a physician may need to repeat a muscle biopsy. But that's the reason, because the way that we've decided, and it's changing, but the way that we've decided that the diagnosis is made is by including all of those features which have to be found on a muscle biopsy. Let's see, I need to figure out how to, okay. So the criteria for diagnosis, and basically what happens is in a room, 20 physicians get together and they decide what should the criteria be for the diagnosis of this disease. And this criteria is important for many reasons, not just because it decides what the diagnosis is, but this criteria also decides what we think of as criteria that might be used for entry into a clinical trial. And so this criteria, can you see my mouse now? No?
Yeah, we can see it.
You can see the mouse. Okay. So what you can, so this criteria is evolving, because you'll see that this criteria is quite a restrictive criteria, meaning that if you don't meet all of these features, you don't have inclusion body myositis. But we know for a fact that patients with diseases very similar to inclusion body myositis may not have all of these features. And so does that mean they don't have inclusion body myositis? Well, no, because it may mean that they have they may not have been seen appropriately on a muscle biopsy. The point is when I think of who we're diagnosing with inclusion body myositis, we want to understand who would be amenable to a therapeutic intervention once that therapeutic intervention is available. And so that's why these criteria need to be less restrictive, because who's to say that somebody who's 44 with IBM doesn't have IBM because this arbitrary criteria said they have to be greater than 45? Or who's to say that because you had a biopsy that didn't have rim vacuoles, but you had all these other features, that we wouldn't offer a treatment that potentially could be amenable or could be an option. So with that being said, this is what the criteria are currently. So greater than 45. You have to have the weakness for greater than 12 months. You have to have this pattern of weakness, which suggests that your quadriceps are weaker than your hamstrings. You have selective finger flexor weakness. And then on muscle biopsy, you need to have these features that I described, which are inflammation. And these are two ways of looking at inflammation that we're going to talk about. And the other is protein aggregation or degeneration. And so going back to this picture here, this is an example of the inflammation. And I think, to me, there are some enigmas in IBM. And one of the enigmas in IBM has to do with the inflammation. And so I feel like this image and many biopsies show this same feature is really illustrative of one of these features, which is that it's an inflammatory muscle disease. So this is distinctive for inclusion body myositis. There are other inflammatory muscle diseases like dermatomyositis and polymyositis, but they don't have this one feature, which is called focal invasion. And you guys can all see my cursor, okay? Focal invasion. And so basically these inflammatory cells here have gone around and they've actually invaded this muscle fiber. But if we go back and look, there are some really ugly muscle fibers here. That's a pretty ugly looking muscle fiber. There's no inflammation really invading that ugly looking muscle fiber. These are some ugly looking muscle fibers. There's really no inflammation around them. This fiber actually looks pretty good. It's nice and pink. It has good internal architecture. This fiber looks pretty nice too. But these are the ones that the immune cells are attacking. And that's one, I think, enigmatic feature of inclusion body myositis is you get focal invasion of normal appearing muscle fibers. And so why that happens is unclear, but I think that some of these images really illustrate that kind of feature. These are actually immune cells, so we can stain these. So this again is focal invasion. So this isn't just this really is an immune cell going into it. So this is a stain showing that a macrophage, that's a cell that normally cleans up cellular debris, is actually in these fibers. T cells, which are another type of immune cell, are actually around and within these myofibers. And this slide over here is a normal muscle. And so normally a muscle fiber doesn't want an immune cell to see it. Okay, and so it doesn't turn on something called MHC class 1. MHC class 1, if you have, we'll go back here, this immune cell here only is attracted to certain receptors. And these receptors that are on cells, and normally they're on immune cells. So an immune cell says, hey, I want to find another immune cell, and I recognize it via this receptor called MHC class 1. And what happens in IBM, and we don't understand why, is normally a muscle doesn't have an MHC class 1 receptor on it. However, in IBM, the muscle fiber has turned into a cell that is saying to the immune cells, come and get me, come and get me. And it's unclear why that is. And so that's another distinctive feature. The other feature that we think about is what I call the degenerative pathology. And that feature is these vacuolated fibers, these kind of smaller looking vacuolated fibers. And in this fiber here, you can see that there is a kind of reddish blob here. This is an aggregate of something. This is an eosinophilic inclusion. It probably has certain proteins accumulating in it that need to be thrown away. And what happened is the muscle fiber said, I can't deal with you right now, so I'm going to put you in the trash can and set you aside. And over time, these can accumulate. This is another feature that happens, which is called a rim vacuole. And this is also an accumulation of debris that a muscle fiber just can't get rid of and can't handle. And these little teeny dots here are also proteinaceous debris. So you've got red dots or red blobs, tiny blue dots, and then you have these holes, and I'll show you in a second, they're not really holes. The other feature is there's accumulation of lots of different proteins. So if we were to go back and look, we'll say we look at this fiber right here, it doesn't look too bad. It definitely doesn't look like this fiber here, but it doesn't look too bad. But this fiber may have accumulated protein, and this is a stain that we can do for certain proteins, has accumulated protein prior to it developing these types of rim vacuoles. So looking for earlier and earlier ways of diagnosing it. And these are again other examples of different proteins that accumulate. And then if you look at that hole, so I said there was this kind of hole here. It's not really a hole because it's actually a bunch of debris that kind of accumulates. And so whenever we do this type of stain here, we actually extract out all of that stuff so you don't actually see it. But if we stain it via a different way, and this is an electron micrograph, so this is, you can maybe see here that this is a muscle, you can maybe see the contractile elements of a muscle. So you'll just have to trust me. This is what's called a Z disc and a Z disc, and this is, so there's muscle here. But in that hole, there's a bunch of just protein debris and membranous whorls. And there's no fancier name for it than that. It's just a constipation of debris that's accumulated within this fiber. And if we look even higher at magnification, so I want you to see we're kind of at this level of magnification. Now we're going to zoom in on like this area right here. You can see that these debris is actually filamentous fibers. And so that's the same type of feature that we see in neurodegenerative diseases, where we see the accumulation of beta amyloid or other disorders. I'm not implying that this is a disease of beta amyloid. I'm mainly saying that the same pathologic features can occur. And so that's the spectrum of the pathology. And so we're kind of left with a conundrum in the idea of the pathogenesis. And this is really where the field is right now. Is the pathogenesis of inclusion body myositis, is it a primary inflammatory myopathy with myofiber degeneration? So is the first thing that's going on, is the primary driver, that it's muscle inflammation that causes these degenerative features? Or is it a primary degenerative muscle disease that has reactive inflammation, meaning that you get degeneration of a muscle fiber and then the muscle says, well, let's get rid of that stuff, and that's why you have the inflammation. And they may sound like the same thing, but they're actually the exact opposite. And so I wanted to kind of go over the evidence for the two and kind of illustrate, again, where we are in the field. So the evidence that inclusion body myositis is an inflammatory muscle disease is stated here. About 25% of patients with sporadic inclusion body myositis have an associated rheumatologic disorder, whether it is lupus, whether it's rheumatoid arthritis, whether it's other autoimmune disorders that are more rare, or even whether it's the presence of immune things like an ANA, which is something that we get at the doctor, even if it's the presence of those. So there is an increase in a patient who has IBM likely had some autoimmune disorder in the past or currently. The HLA genotypes, so these are genotypes that are specific to immune cells, and these are the most prevalent risk factor for getting inclusion body myositis is actually having a certain genotype of HLA. And so I feel like I'm not explaining this perfectly. So an HLA genotype is something, so people that have a certain type of autoimmune disorder called ankylosing spondylitis have an HLA-DRB2 genotype, have an increased prevalence of it. And so people who have multiple sclerosis have an increase in a HLA and another type of, I don't know what it is, DQ7H genotype. And so in IBM, there is a specific genotype, and I don't know it off the top of my head, that seems to be a risk factor, suggesting that a certain immunophenotype is present in these patients. Rare patients with HIV infection, hepatitis C, and even HTLV1 can have an IBM-like syndrome that happens much earlier than age of 55. The most dramatic being in patients who have an acute onset of HIV and can develop an IBM-like syndrome. Now, there are many people that have HIV that don't get IBM. So I don't want to say that it's causal, but I want to bring up the idea that it's kind of interesting that a patient with HIV, an immune dysregulating disorder, could have an IBM-like syndrome. And then most exciting in the last several years is the identification that there are myositis-specific antibodies that can help us understand inclusion body myositis. These are not perfect, so there are a lot of myositis-specific antibodies that are really great, things like JO1 and SRP, where the sensitivity and specificity is on the order of almost being diagnostic. I shouldn't say almost being diagnostic, whereas the sensitivity and specificity is around 60%, so it's not perfect, but it is intriguing that an immune antibody can be associated with this. So what about the flip side? What is the evidence that this is a degenerative muscle disease? Well, the very fact that it only happens in patients over the age of 50 is really, and that's the #1 risk factor for the disease, is really evidence that there's an age-associated degenerative phenomenon going on. You would expect that if this was purely an autoimmune disorder, that it could happen in kids, because there are myositis that can happen in kids. And so this very fact itself suggests that there's some aged element that's going on. This is the other aspect, the fact that it's refractory to immunosuppressive therapies. And you could say, well, we just haven't found the right immunosuppressive therapy, and that's quite plausible, but nothing seems to really be beneficial. Every known, and I'm going to get caught if I say every, but most inflammatory muscle diseases have some response to prednisone. And the fact that IBM has limited response to prednisone, to me, suggests that there's something else going on. There are pathologic and clinical similarities to several hereditary and genetic myopathies that look like IBM. And you might say, well, they don't have any evidence of inflammation. Well, that's actually not true. Some of the hereditary forms can have inflammation being a part of them, and can look almost indistinguishable. So the fact that a genetic cause can look like IBM, sporadic IBM, to me is helpful in thinking about it. And finally, mutations in proteins that are associated with hereditary IBM have been shown to be risk alleles for patients with sporadic IBM. And so I want to get cautious with genetics when we talk about a genetic disorder, because we're talking about risk, and we're not talking about if you have the mutation, you're going to get it, or if you have the mutation, your children are going to get it. We're talking about that if I take a cohort of 100 people that are normal, and I take a cohort of 100 people with IBM, that there's an overrepresentation of a certain disease mutation allele. That's what we're talking about. So we're not talking about causality as much as informing us about risk and perhaps mechanism. And so the idea here is that, as I said, we're on kind of two sides of a coin. Is this a degenerative muscle disease? Is this an inflammatory muscle disease? And the research over the years has really shown that. And so this is looking at current and past clinical trials in inclusion body myositis. And all I did was get on clinicaltrials.gov and put in inclusion body myositis, and pulled up some of the more recent inclusion body myositis trials. This is not an advertisement for any of these trials. It's more just saying, look at, it's exactly what we just said. Half of them are focusing on inflammatory causes, where we're looking at a drug called etanercept here, which is being used in rheumatoid arthritis, and seeing if that can work. Or we're using a drug that's also called Campath, and seeing if that can work. These are autoimmune mechanisms to try to work at. the other arms are looking at, can we improve the degenerative features? Can we improve muscle growth by inhibiting certain factors such as myostatin pathways? Or can we improve the clearance of protein inclusions with a drug called arimoclomol? And the reason I point it out is because what I really think we need to start thinking about is somehow ways of integrating these two pathways. It may be that that there is a place for autoimmune mediated therapies, but they will need to be supplemented with other types of therapies that are focusing on the degenerative aspect. And so I think breaking down the silos between these two camps of people that are focusing primarily on a degenerative aspect and people focusing on primarily an immune aspect, and somehow bridging that conversation, but also thinking about how to bridge the therapies as we move forward. And I think this is my last slide, and I'm happy to take any questions or go back over any of the slides if anyone has any questions.
Thank you so much, Dr. Weihl. Do you mind stopping the share so we can see you?
Sure.
And I have one question quickly about what we just saw. Lithium in treating IBM. Any ideas on what the connection would be there?
Yeah. So so one of the challenges in inclusion body myositis is there's no so to think about how you go from patient to drug. One of the key steps that people, and I say people, I mean drug companies, and even the FDA want, is they want proof of concept in an animal model. And as we just talked about, sporadic inclusion body myositis is a sporadic disorder. So there's no clear animal model that's perfect. There are animal models out there that people have used. And so one of the animal models that was used was a model where they overexpressed a protein called amyloid precursor protein, and they overexpressed another protein called tau. These are proteins that are in Alzheimer's disease. And in that study, with that animal model, they were able to show that they could improve the muscle performance in this mouse model by giving lithium. And lithium can do two things. One is that it can inhibit the phosphorylation of some proteins, and it can increase the clearance of proteins as well. And the reason that that was exciting was because lithium is safe. Lithium is something that many physicians have clinical experience with. Lithium is cheap. It's salt. It's lithium chloride. It's salt. It's cheap. And so to do a clinical trial for that type of study is much cheaper. The risk benefit is much simpler because if it doesn't work, you really didn't put any money into figuring it out. You know, you didn't do any toxicology studies. You didn't have to figure out the dose. And so that's part of the reason that became a clinical trial. I have no, I don't think it's going to work. And I'm not even sure what's happened with that trial. My guess is nothing's happened with that trial. But that's one of the reasons that we look at these trials and we see promise like that. I can see how it's not entirely intuitive to a patient what the background is in that. But that's what the background is.
All right, I was just interested to see that. I hadn't seen that on the trial site, so thank you. Jim, you had a question? Matthews?
Yeah. A lot of people firmly believe that their IBM was caused by exposure to statins, which can cause myositis, but not necessarily IBM, or to a vaccine. Is there any links in either of those instances, Chris?
Yeah. So that's a great question, and so to rephrase the question are statins, have statins been demonstrated to be a risk for inclusion body myositis? And the answer is no. There's no evidence for that. It is quite possible. So it's a challenging thing to figure out for a couple of reasons. Is statins are so pervasively utilized in the world. Statins are, I would say, I don't know the data, but I'll probably be on a statin someday. I mean, I think everybody's going to be on a statin someday. So they're quite prevalent, and IBM is quite rare. And so it makes it challenging to do those types of demographic studies. The case of, I'm not answering the question well. I mean, you bring up a good question. I can't say anyone's looked clear enough. There probably would be ways to figure it out. There's no evidence for it. I think that I think you're. I mean, you're bringing up. I mean, there's no. I can tell you what the party line is, which is that there's no evidence of it, and I don't see it clinically. I see, it's very real to the patient that has it, but I don't see it clinically that it's that. And I don't argue against being on it. I think statins are great medications, and I think I would hate for it to be seen in any muscle disease, except for statin-associated myopathy, that statins are not to be used, because statins have great track records of saving people's lives. And the goal and hope and prayer for me is that patients with IBM live long, healthy lives. And I don't want to say don't take a statin, because that we know is going to give you a long, healthy life. So I think that's my reluctance in saying whether it could be Jim.
Great, thank you. Linda.
Hi.
Hi, Linda.
Hi, Dr. Weihl. I have a question about that. You said the rim vacuoles, the debris. On mine, it showed, I always read pycnotic nuclear clumps or whatever. Are those the same as that cellular debris, or?
No, I can show you a picture of them really quick.
Okay.
Hold on. I got to share the screen, which is here. So if we go back to this very first image here, so a pycnotic nuclear clump is actually, so I'd said that there's these types of fibers here, and then I said there's smaller fibers, and then there are even smaller fibers. And so this is a fiber right here, and it's got, most fibers have, 1, 2, 3 nuclei that are around it. Muscle's unique in that it's a syncytium of multiple nuclei. And so this fiber here has 1, 2, 3, 4 nuclei. And as this fiber shrinks and gets smaller and smaller, those nuclei are right here. They're called pycnotic nuclear clumps. And so this is actually an accumulation of probably 1, 2, 3, here's 3 nuclei within a very small fiber. So all a pycnotic nuclear clump is saying is that you've got really, really teeny muscle fibers. That's really all a pycnotic nuclear clump is saying. So it's a very different feature, but it's an interesting feature, because what does that say about how the cell's dying? So it says that the cell isn't just exploding. The cell is getting smaller and smaller and smaller. Like if you were a cell and you wanted to die, you would get rid of your nuclei too. But you're maintaining the nuclei in this kind of smaller and smaller and smaller atrophic fiber. So while it's not what you were describing, it is an interesting feature that's consistent with muscle atrophy that occurs in the disease.
Is that for all IBMers that have
It's
that?
It's a feature in IBM. It's not a required feature in IBM, but it's a feature in many different muscle diseases.
So it's just kind of a survival mode for the cell?
One thing it does speak to is to get to that point, you have to have a pretty chronic muscle disease. And so it does speak to the chronicity. You know,
Okay.
the other aspect that I always think is intriguing is we assume that this little guy right here, this fiber right here, is gone.
Yeah.
Like we should just give up on it.
Yeah.
But it still has its nuclei in it. Maybe with drugs like bimegrumab, which increase muscle fiber hypertrophy, maybe this guy isn't too far gone, and maybe we can wake him up and make him bigger.
Okay.
So, you know, the other option is the other form of death that myofibers have happen, and it doesn't happen in IBM, is necrotic cell death, where basically the fiber just explodes.
Yeah.
So there's something very controlled going on.
Okay. Huh. That's interesting. Thank you.
Sure.
Yes, thank you. Thanks for the question, Linda. Let's see. Ed.
Thanks, Sherry.
Yes.
Hi, Doc. I just had two quick questions. One was a curiosity more than anything else. I have an IBM pretty classically. It's in my forearms and in my quads. But I also noticed that my biceps and triceps are deteriorating at a pretty strong rate. I don't feel, I can raise my hands up. I can lift small weights. My hands usually are the ones that give out. So I hear all this, these affected muscles that you don't typically hear, including the heart muscle. And I'm wondering, what we know about beyond classic IBM symptoms, what other muscles it might be affecting.
Well, so that's a great question. All so we're talking about stereotyped patterns of weakness whenever we talk about quadriceps and finger flexors. Those are helpful in understanding a pattern of muscle weakness, but in an individual person, different patterns of muscle weakness can occur, and so it is quite possible that someone with IBM could develop weakness in patterns that are not typical. And so I think although we say there are muscle fibers that are more affected and muscle fibers that are less affected, I think the truth is that all muscle fibers likely could become affected. The question would be, when would that happen in the disease course? So I think many people will end up developing more weakness in other places. The cardiac issue is probably not a concern. The muscles of the heart and the muscles of the skeletal muscles are quite different. They're quite different in the way they're organized, and they're quite different in their makeup. And there's really no evidence of inflammation in the heart. So that's not to say that a patient with inclusion by myositis can't get heart disease. Everyone can get heart disease. But what I'm saying is that the same pathogenic mechanism of deterioration due to an autoimmune or degenerative feature in the heart is probably not going on in sporadic IBM. And I think that data is pretty strong. I think we have enough patients that we've looked at their hearts post-mortem and know that their hearts don't have the same classic features. Did I answer your question?
You did, thanks. And the other question I had, you answered it very well, thanks. The other question I had was, can you speak to the seemingly significant delays that happen in these clinical trials that keep getting pushed out and out? What is that a process of bureaucracy of the FDA, or what does it mean? Yeah.
So I have a whole other talk on that. I'd be delighted to come back and talk about that at some point. The short answer is there are so many steps that go into it that some of them I don't fully understand. Some of them are clearly bureaucratic in certain ways. So is there one that you're thinking of in particular, or?
I was thinking of arimoclomol that has been hovering about
Yeah, arimoclomol. So the arimoclomol trial is mainly bureaucracy. You know, it's who owns the drug. It was bought by another company. The trial itself, and I give full credit to Mazen Damaschke, who really did this trial out of academia. So for me to do a clinical trial out of academia, meaning that I have no drug company support, that I am asking the NIH and FDA to fund a clinical trial is, I mean, it's unheard of. And Mazen took that on and did that. Now that the trial's showing some success, guess what's happened? The drug company is now interested in the drug now, and now they're wanting to switch everything over to their paying for it. And so now there's another delay right now. So I mean, they had it going, you know, granted it limped along, but they finally got it to a point. And so, you know, I don't bemoan that in some ways. I feel like in some ways my job as an academic physician is to de-risk things. Can I de-risk drugs or de-risk concepts and pathogenic mechanisms so it can entice a drug company? So but that's what happened in that. You know, I never want to forget that it was Mazen Damaschke's idea, and that if this thing ends up being a success, he's really the one that pushed it through.
Thanks. I appreciate it. That was a good answer.
Great. Thanks, Ed. Let's see. Brian.
Hello, can you hear me?
Yes.
Yep.
Good, good. Yeah, I was in the BYM 338 trial, and I could talk about that for a long time, but I do agree with it, what you were just saying, Dr. Weihl. As a matter of fact, I have a lot of research that, sorry about that, I got something reminded me to do something. Yeah, I think that the pharmaceutical companies have a lot to do with it. And also, when you folks in a university do research, for an example, the follistatin trial, the doctors that discovered, one of the doctors that did the main research on that started up a biotech company and now owns the rights to the drug. And how that fits into the ethics of it, whether that's the right way to do it, you know, I mean, you folks are, you know, work hard and everything, and are, but I don't know if that's the right way to reward academia people by letting them get the rights to things that they've discovered through taxpayers' money. So I just kind of wonder how you feel about that.
Beyond my pay grade, you know, those are beyond my pay grade. You know, those are bigger questions that I just try to work within the I feel passionately about what my responsibility is. You know, my responsibility is to point out therapeutic targets, and so that's what I feel like is my responsibility. I mean, I'm not sure. I mean, the idea that that somebody's going to make millions and millions of dollars off of solving sporadic IBM may be a bit naive in itself too. So I don't know. I really can't comment too much. I mean, my comments about, so I have lots of comments about drug company sponsored trials, and I think they're awesome because they increase awareness of the disease. They identify cohorts of patients that are amenable to a clinical trial. They help us understand, even if the trial fails, they've helped us understand the natural history of that disease. They've helped us understand what a good clinical outcome measure should be. And so even if it's a clinical trial that I may not be enthusiastic about from understanding the cellular mechanism, I'm excited about all trials that increase the understanding of IBM. This is a rare disease. We think we understand the natural history of the disease, meaning we think we understand how people get weak and their pattern of weakness and their time frame of weakness, but we don't know what that looks like in a cohort of 150 people. We may know what that looks like on an individual basis, but not when we group people together, which is how we do clinical trials. And so, so I will say that I do have that sense of commitment, and I think that the only people that have the funds and resources to do those types of things are drug companies. The NIH is not going to pay for me to follow 150 people every 3 months and have a physical therapist see them. They're just not. Where a drug company can do that in the context of a clinical trial.
Great, thank you for that. It does help to clarify some things. Kim, you have a question?
Yeah, so I have a question about the NT5C1A antibody. So my husband had some testing done through Mayo Clinic, and they tested that antibody, and they sent it out to the lab in California, not the lab at WashU. And his value came back in the moderate range, which the number was 54. I don't know what that means. So I guess we're just have confusion as to what is the value of that as far as diagnostic value.
Yeah. So, we're still trying to understand what the value of that antibody is. So just so everyone's on the same page, this is an antibody that was recently identified, I think 3-4 years ago, by 2 independent groups. And so in a patient, basically, let's talk about how it was identified first, and I think it'll help us understand the utility of it. So basically what they did is they took, like I said, 100 patients with IBM, and they looked to see if there was anything unique or specific in their blood compared to 100 patients that don't have inclusion body myositis. And they found and they were looking specifically for an antibody. So they found an antibody, and this antibody was to something called NTC5-1A. And then what they did is they said, well, we think we see this antibody. Let's see how specific it is. How many, is it in every patient with IBM, or is it in only some of the patients with IBM? And they found that it was in 40 to 60% of patients with inclusion body myositis. And then they said, well, if this thing is really as good as we think it is, then it shouldn't be in anybody else. And then they looked in patients who had diseases that weren't IBM, and they found that actually about 20% of patients that don't have anything have this antibody. And so now we're left with an antibody test that isn't perfect, meaning that if somebody has the antibody, so now let's step back and say someone comes into the office and they have weakness, and I don't do a muscle biopsy, I don't examine them, I don't do anything, I just order this blood test, okay? So the odds are, just because of the odds of who has IBM, is that that test isn't going to be very good at screening, because the odds of somebody having nothing is much greater than the odds of them having IBM. It's 5 in a million people. And so, so just playing the odds, that is not a test that would be good for screening patients. It would not be a good test to give to primary care doctors and say, hey, on your health test, I know you check a PSA, and I know you're going to get a mammogram, and you should also check this antibody. That would not be a good use of that. So then the question is, well, what would be a good use for it? So a good use for it might be if somebody comes in to see somebody that's a specialist who's thinking about IBM, And they say, you know what, your weakness looks, what I think of as somebody with IBM. You meet all the criteria. You haven't had a muscle biopsy yet, but you meet most of the criteria. Why don't we do this one blood test and see if it's positive? And if it was positive, you might say, yeah, you have inclusion body myositis. Or somebody who has a muscle biopsy that doesn't meet all the features, and they say, you know what, let's do this blood test. And if it was positive, that would be very helpful. If it's negative, which it will be in 40% of the time, it didn't help you at all. And so it doesn't mean you don't have IBM. And so then the question is, what you experience then is, so once we have a test, I can actually look and see who has more of the antibody versus who has less of the antibody. And I can do something where I can do it tighter. And that's what they did. And so they identified whether they were in a moderate or high range. And unfortunately, we have no idea what to make of that. The way we read it here is plus or minus. You have it or you don't have it. We are collecting data to know. So that's where basically over time, my vision is that we will collect enough patients and we'll be able to correlate something different about a patient who has a high titer versus a low titer. We may be able to say, so it would be great if someday you could come in with your pattern of weakness. I could say, let's check this antibody. And if your antibody was a high titer, I could say, you know what? You're going to progress in this way, and in 7 years, you're going to need this assistive device. And someone comes in and they don't have the antibody, and I could say, you know what, you still have IBM, but you're actually going to have more breathing problems, and we should really monitor that more carefully. So that's one way that that antibody can be used, is to help dictate prognosis. The other way I believe that it's going to happen is it may be that we'll be able to say, you know what, if you have this antibody, you actually might respond to, treatment A. And if you don't have this antibody, you may respond to treatment B. And if you have a high titer of this antibody, you actually respond to treatment A plus C. So really it's a way of personalizing medicine in some way. And so that's what it's used for currently. So right now, I wouldn't think anything of it. There's some data that suggests that patients with the NTC518 antibody progress more rapidly. I don't think we know that for sure, and I wouldn't think anymore. I would never check it again. There's no reason to. It's not like checking a blood test like that. It's either yes or no, and the answer's already been figured out.
Okay, so probably if he'd had it tested through WashU, he just would have been positive because it did go up. Okay.
Yeah.
And that was my next question, because he's only 48. So I was just wondering if, we tested 5 years from now, if the titer would have gone up and what that would have meant.
I don't think it's not going to change anything.
Yeah.
It's not going to change anything. I think, I envision someday that we may want to understand it better as far as treatment response. And so I think checking it, so the hope is for clinical trials that people will check this antibody, and then you do post hoc analysis where you say, well, actually on total, no one got better, or it sounds negative, but on total, there wasn't an effect. But actually, if we look at the patients that were NTC518 positive, actually there was a hint of effect. And now let's do another trial where we just use those patients. So I think it's important to know.
Okay, because we still don't have a definite diagnosis. We just have lots of little things that point to IBM, but nothing specific. So
I would not hang my hat on that antibody being,
okay.
I would not, in fact, if it's probably diagnostically is one of the least important features.
Okay. All right. Thank you.
And Kim, did you also have a question about prednisone?
I have lots of questions. Yeah, I mean, my husband just started prednisone a couple days ago. So because our insurance company they won't cover the IVIG. And not that we think either one of those is particularly going to work, but we just felt like we had to start with something. So I wasn't sure if the prednisone was going to be something that was dangerous for him to take at this point, other than the normal side effects of prednisone. But as far as IBM goes.
So my experience with patients and with IBM is that in conversations with the patient and in conversations with the family, we discussed whether a trial of high dose corticosteroids is a reasonable thing to try. And so that's a conversation you should have with your physician. In my opinion, I don't think it's unreasonable to give a trial of corticosteroids. The caveat is you've got to know when to stop it if it's not working. And so I really engage the patient and family into thinking about what would be the effect that we would expect that would say that we could continue it. Because my experience is often is we treat somebody with corticosteroids and we wait, and when we do a decent trial, we do high dose for 3 months, and we see them again, and I say, do you think you're any stronger? And they say, maybe I got a little energy. That's not a resounding, that's not a response. We know from an inflammatory muscle disease that if you respond to corticosteroids, you're going to get stronger and you're going to know it. And so that's my only caveat is long-term corticosteroid use can be dangerous. And the last thing you want to do is then get in a cycle of, well, let's try this chemo, or let's try this autoimmune therapy. Let's try this one. So I just, to me, it's a conversation that really needs to be thought of. And another thing is everyone's CK will go down with steroids. Mine will go down with steroids. Everyone's will go down with steroids. So that's not the answer either.
Great, thank you. Joe?
Where do you stand with physical therapy and staying active to slow down the symptoms of IBM? I do a lot of walking and stretching combined with rest throughout the day. I find it helps me with my symptoms slowing down, but as soon as I get tired, my symptoms all pop up. So I had to learn to manage activity with learning to rest before I get tired. Where do you stand with that in physical therapy and exercise and activity?
Yeah. So I think there's a couple of aspects. So one is that I'm going to talk about it from a scientist standpoint. So one thing that we know and that we didn't know before, it may seem like you guys are going to be like, oh, it's obvious. But I can tell you as scientists, we didn't know that a patient with IBM could get stronger. We didn't know that an affected muscle could get stronger. And so we do know now that an effective muscle can get stronger, meaning that if you exercise that muscle, it can gain strength back. And so with that being said, what we don't know is, does that make any difference in the long run? Okay, so the study showed that if you did aerobic exercise of an affected muscle 30 minutes, 3 times a week, that 6 weeks later that muscle was stronger. That's all I can tell you about exercise and strength. Does it? But I can't tell you is, well, did that keep you happy, healthy, independent in your home 15 years later? I don't know the answer to that. What I can say is that physical therapy is good, and I think that it needs to be personalized to the patient. I think exercise is good. We know that in patients with chronic muscle diseases, that increasing your heart rate to 70% of VO2 max, like I just said, 30 minutes, 3 times a week. I'm not asking anyone to go change their life to become an exercise person. I'm saying 30 minutes, 3 times a week. We do know that increases muscle health and muscle strength in patients with these diseases. And so I recommend that to everybody. And it's not focusing in that study there. It's not necessarily focusing on the weak muscle. It's really, and it's unclear why, but it could be it's increasing vascular perfusion. It's unclear why increasing your heart rate up. Aerobic exercise was important. And in doing that, it doesn't have to be the affected muscles. Stretching is important. Things that keep mobility are really important. I think that working on balance and walking, I think, is important. There's caveats to all of these, which is that I want people to be safe whenever they exercise. It defeats the purpose if I say go walk around the block and you fall and break a hip whenever you do it. So I can't hold your hand while you're doing it. So some of it has to be, there's no magic for everybody, but do it safely. I often tell patients, they want to go to the gym and they tell me how great the elliptical is. And then you talk with them more and they've got to have 2 people help them get on the elliptical and 2 people to help them get off the elliptical. Well, that's not the right equipment for you. That's just not. Doesn't sound safe to me that you can't get on and off the equipment. So I think just thinking about it, and I really encourage patients to advocate for themselves with physical therapists. I really encourage for them to have a dialogue with a physical therapist. A physical therapist their goal is they want you to get stronger. That's what their goal is. That might not be your goal. Your goal may be, like I said, to stay happy, healthy, independent in your home. And that may not mean you need to get stronger. And so you need to convey that to your physical therapist, because my experience is that some community physical therapists get very frustrated with chronic diseases because they're used to treating injury recovery or stroke recovery, and those patients get stronger. And that may not be the goal.
Okay, thank you. I started my exercise and activity with a physical therapist. I had 85 sessions in 6 months, and it's changed my life.
That's great. And do you have a conversation with her and let her know what?
We had 85 2-hour sessions, and it was based off. She'd have a stretch to do, or he had a stretch to do, or an exercise to do, but it wasn't based off reps. It was based off, you had 2 minutes to do this one. You know your body, what you can or can't do. I don't care if you did 5 or 2. You adjusted to how your body felt that day. And she had like 20 different exercises, but nothing was more than 3 minutes, and nothing was based off reps. It was what my body was telling me I could do safely. The main thing she wanted me to do was stay active and just try. And it worked out. Now it's part of my daily life.
Okay.
Thanks.
Great. Thanks, Joe. And thanks, Dr. Weihl. I know you have a busy
I'm okay. I can 10 more minutes.
10 more? Okay.
Is that all right?
That's fine with me.
Okay.
You're available. Let's see. We had a question about the biopsy slides that you had shown. Were those taken from a newly diagnosed IBM patient, or maybe somebody with advanced disease?
Those were taken from, that was a newly diagnosed patient. The challenge of doing a muscle biopsy is picking the appropriate muscle. And so picking the muscle that, so you don't want to pick a muscle that's too weak, because you may not find the features that you want. And you don't want to pick a muscle that's too strong. So in any patient that we're suspecting IBM, we really are careful in trying to identify which muscle to take it from. But yes, it was a newly diagnosed patient.
Okay, great. And in that same question, are biopsies ever repeated on an advanced IBM patient?
Not necessarily. If there's a question, the only reason we repeat the biopsy would be if there's a question of the diagnosis. And so the way that would happen would be As a physician seeing patients in clinic, I have a few responsibilities. One of them is to appropriately diagnose a patient. And I think patients often get frustrated because I will reevaluate their diagnosis every time they come into clinic. I have no shame in saying I was wrong, that this is what I thought you had today, but in a year later, you know what? Something happened that made me think that's something else. So I will rethink of everyone's diagnosis at every visit. And so if there's a question of the diagnosis, I might recommend rebiopsying. The things that would make me question it would be that my second job is to make sure that what I told you had, you're progressing in the way that I would have expected you to progress. So if a patient with IBM all of a sudden starts to develop rapid weakness somewhere, that would be a red flag to me to say, you know what, Chris, I think you've got it wrong, and maybe you need to reevaluate this patient. So there may be a reason why I would rebiopsy. The other reasons you might rebiopsy would be if like I said, the diagnosis wasn't 100% clear in the first place. There are some clinical trials that require certain features on a muscle biopsy, so you might rebiopsy someone for that. But there's no reason to. It's not going to help you. It's not going to help me unless I'm confused, and then it would help.
That makes great sense. Thank you. Any link to diet or supplements that can be helpful with IBM?
Yeah, there's not. This is where I learned so much from my patients on different types of diets and things like that. There's a really so there's no evidence, and I am the first to admit that I don't even know the evidence. And Linda's on here, and she knows that I'm the first to say, I have no idea even where to start. There are resources out there that I think are valuable. My biggest claim is that if someone is selling you something that they say is magical, I don't have any problem with you trying it, but at least, if it's going to break the bank, be a bit skeptical of it in some ways. There's a great website for ALS, which is called ALS Untangled, and I would actually encourage people to look at that website, because what it does is it looks at alternative medicine therapies for ALS, and it does a really thoughtful, systematic, kind of unbiased approach to say whether there's any evidence that this might work. And so it hasn't been done for IBM or many of the myositises, but it would be interesting to think about a platform like that where people could submit and say, I heard that, so for the ALS one, it goes as crazy as, does Dean Kamen, energy healer, he says that he can cure ALS, and they do it in a very thoughtful way and say, let's just assume he's right. What's the evidence? Let's go meet with him. Let's go talk to patients that have experienced him, and then they come with a conclusion. Another one that patients ask me in ALS is coconut oil. I hear coconut oil works, and I say, I have no idea if it works. And so we go look on that website, and there is some evidence. Definitely there's evidence that coconut oil is not going to hurt you. And so that's an important thing to know. And so but as far as diet, there's nothing that I know of. And I think it's, my other bias on diet is that everyone wants to control what goes inside of them because they feel out of control with their disease, and how much of it is diet versus how much of it is I just got to control something out of this disease. So.
Yeah, I agree with you. We see a lot of it in the groups with some of these really extreme diets, and you're on. This is for all myositis patients. So some of these are DM, PM, and they're on these crazy medications, and they want to do like the 7-day water fast, and I'm like, please talk to your doctor first. Don't just do that.
Right.
But it's just my opinion. But on just as a follow up to that question, what about a high protein diet? Do you think that would make any, or in IBM with protein clumping, do you think there could be?
Yeah. So that's another area. So, the simplest things we are just not good at doing in some of these diseases. So, high protein diet, should there be high repetition exercise, low impact exercise? We just don't know the answer for many of those. I think high protein is probably reasonable. I think definitely if you're going to do exercise, whenever you do, so we know that just in normal people, that if you exercise, your biggest time period of protein of muscle breakdown occurs about 20 to 30 minutes post-exercise. And so that's why, the bodybuilders use protein shakes right after they exercise, or right after they weight lift. And so I think that's a reasonable thing to do. I think it's reasonable for anyone with not just even IBM, but with just, muscle weakness in general, who's exercising to take a protein shake, with exercise. I think that's reasonable. I don't think there's any evidence that changing to a high protein diet is going to improve things in the long run. I take diet very, diet is hard. Like me giving you a medication is easy. Me telling you to go on a certain diet is life-changing. And I don't ever want to discount those challenges in our patient population. What may seem easy to me, living in the city to go get, fresh produce may not be the same for other people. And so I don't think we know the answer, but I also want to be really mindful of meeting people where they are. And I think there are more things to obsess about than what you're eating, in some ways,
Thank you for that. Appreciate it. Looks like we're running out of time, but I did want to touch on one thing, unless you have more time.
No, this will be good.
Okay. Since we haven't really discussed swallowing issues so much, we have a patient, Mary. Her husband is at IBM for over 20 years. He had esophagus dilation, helped with the swallowing, but not with the mucus.
Not with the what?
Not with the mucus. It helped with swallowing, but not the mucus. Wondering if you could recommend some type of a cough assist or a suction machine, really about choking mainly.
Yeah, so cough assist is a reasonable thing to use. There are ways of helping to dry out. So the issue with mucus and saliva is that you're not clearing it as well. And so reducing its production can be another way of doing it. So a cough assist can help with the clearance of it, but the other way would be to reduce it. And so there are some medications that their side effects are actually they dry out mucous membranes. It can often be beneficial in that situation. One of them is a fairly safe medication. It's a tricyclic antidepressant, amitriptyline. It's very easy. It can be taken at a very low dose.
They use that drug for a lot of things.
They do. Well, because it's you know why? Because it's an old drug that had lots of side effects, and so these old drugs, the side effects, many of them were these kind of what we call anticholinergic, and so that's why we use it.
It's neat that you find that you can use it and that it is pretty safe to use.
Yeah, and it's cheap.
And it's cheap. Yeah, very cheap. Great. I didn't mean to interrupt you there. It's just
no, that's okay.
I've heard that being used for so many different things. So, well, thank you so much for answering those questions and for giving us such wonderful and practical ideas and ways that everybody can probably understand it. I think that's sometimes what we miss.
Great.
So, so with that, I again want to thank you. We welcome you back anytime. That talk about clinical trials sounds like.
Yeah, no, I'd love to. I think that's a great. It's a question that everyone always asks.
Absolutely.
And I think that I'm into empowering patients, and I think empowering them with knowledge is really important. I may be wrong. Maybe it just brings up more questions, but I feel like it helps understand where. I think the most important thing is understanding where patients can connect. One of the biggest and one of the most amazing things about the IBM community that's happening, and has been happening for several years, is getting people together, and whether that's you know, a lot of it probably relates to social media, to sites like this, but just the fact of getting people together is very valuable, because it then becomes more of a reality to approaching a drug company and saying, I know this is a rare disease, but I just got 15 of them on the phone at the same time, and it can be done, and it's not as challenging as you think, and then increasing awareness of the disease, and increasing the awareness in, I think, meaningful ways. So I think that I think there's a lot of efforts being put into Alzheimer's disease, and how we think about memory loss, and how we think about loss of memory as being something that that just happens as we get older. And that dialogue has changed. The dialogue has changed a lot. I don't think anyone believes that anymore. And so that dialogue needs to change for muscle weakness. And I'm not saying it needs to change because we need to change it for IBM. We just need to change it so that people start getting diagnosed, thinking about it, and going. And so the life that's robbed of a patient with Alzheimer's disease is equally robbed from a patient who has mobility issues, and it needs to be stated to primary care physicians that that it's not to be dismissed. It's not always because of a back injury, so that's I think an important thing that patient advocacy groups can do. All right, I feel like I went on.
Hey, we appreciate it. It's always great to hear the ideas that, you know, guys like you that are so intimately involved in the research and the science feel that is the important, because that's part of our mission and goals. So it's good to have that validation, I think. So
Great.
Well, again, we thank you. And
all right, well, thank you, everybody.
Anytime.
All right, bye-bye.
And thanks, guys, for joining us today. You can visit understandingmyositis.org for upcoming video sessions.